Okay. So
Full
excess,
screen, sir.
Sir, do it a full screen view.
yeah, I'm just, yeah.
Yes.
So X-ray spine was ordered, that was normal. So obviously asked for the DEXA scan, and the T-score at femoral neck was minus 2.5. So orthopedician labeled as early onset of osteoporosis referred to our department. So she was investigated, and as usual, the all the investigations for the secondary osteoporosis worked up. Calcium profile was normal, vitamin D was normal, PTH was normal, and the all endocrine profile was normal, including the screening for the celiac disease was normal, and as well as for the bicarbonate level was also normal. But recently we are seeing lot of patients with the milk intolerance, or you can call lactose intolerance. So hydrogen breath test is done, and that was positive. So this patient was just put on the asked to stop the milk and continue with calcium and vitamin D supplementation. So you can see within just 1 year, at the end of the 1 year, there is 23% rise in BMD at the spine, as well as the femoral neck, approximately 30%, and the radius 30%. So by this patient, we can learn or influence two things. One is that either that patient is osteomalacia, but the against that is the alkaline phosphatase was normal, or second, this patient is having the malabsorption because of lactose intolerance, should not achieve the peak bone mineral density. So what is in young patient, this is a common problem to look for the peak bone mineral density and compare the T and a G score and try to find out the what is the cause for the osteoporosis. So subsequent my talk will be like magnitude, pathophysiology, osteoporosis in young with relation to peak bone mineral density, etiology, diagnosis, and a brief about the treatment. So we all know that postmenopausal osteoporosis is very common, and men above 50 years osteoporosis is common. Compared to that, young osteoporosis is less frequently seen, and even it is seen, it is difficult to manage and diagnose also. And sometimes it is further difficult in children and adolescents as well as in young adults. So looking at the magnitude of the problem, so one of the epidemiological data from the Olmsted County at Minnesota, they screened the patient of 20 to 40 years of the age, and they looked and they found that 4.1%, one per 1 lakh people were actually having the osteoporosis. In another study, 570 premenopausal women, Spanish women were screened for the osteoporosis with the lumbar spine BMD, and they found that 0.3% of the women had osteoporosis and 13% approximately having the osteopenia. So compared to the classical postmenopausal osteoporosis, the prevalence is very less and the magnitude is uh, much less. But to understand the to understand the uh, osteoporosis in young, or the we have to little bit know about the peak bone mass, because if the peak bone mass is not achieved, it will always be a problem, and it is always diagnosed as osteoporosis from day one itself. So and peak bone mass is also one of the major determinant of the osteoporosis in the young. So what determines the peak bone mass is that one is genetics is very important, and it accounts for 50 to 80% of the variation in the peak bone mass. Second comes is the nutrition. Protein and calcium intake plays a very important role to achieve the peak bone mass, in addition to the good physical activity. And various hormonal factors, of course, and being endocrinologists, we all know that almost all endocrine disorders can affect in bone in one or other way. And the most notorious one, the Cushing syndrome and the deficiency of the gonadal steroids. So here in this slide, there is a difference in the peak bone mass. So dotted lines that is showing for the peak bone mineral density in the men. And you can see that approximately at the age of 25 years, the peak bone mass is achieved. And there is a lower line, which is the continuous black line that is showing the peak bone mineral density in the female. So there is a gap in the peak bone mass between male and female. And the lowest line, you can see the dotted line, small and big squares, and you can see that when there is a any chronic disease or suboptimal lifestyle factors are there, then this particular patient will never achieve the peak bone mass. And from as early as maybe 40 years or 40 years of age, he will be diagnosed as having the BMD in the range of osteoporosis. That's why it is important to know about the peak bone mass. Otherwise, we are frequently diagnosing the osteoporosis in the young people also. So, at what is peak bone mass is achieved? There is a lot of confusion in this regard, because as you have seen in the previous slide, that peak bone mass is achieved in 25 years. So we did recently one study, that is bone mineral density in healthy adult Indian population, with the name of Cube study, that is Chandigarh Urban Bone Epidemiological Study. And what we found here is that uh, peak bone mass is achieved in the women at the age of 30 to 39 years, and that is consistently observed at all four sides, whether it is a lumbar spine, whether it is a femoral neck, total hip, or the 33% of the one third of the radius BMD. So meaning by that, one thing is clear, that our peak bone mass is not achieved the age of 25, which is classically seen in the Western database. When we looked at peak BMD in the men, again the situation is the same. In men also, there is peak bone mass is achieved between 30 to 39 years at the lumbar spine, femoral neck, and total hip. And also there is consistently further decline in the BMD, with peaking in the 30 to 39 years of age. When we search the Indian literature about the peak bone mineral density, and the results are much closer to our study as compared to the Western study. The one of the study published by Dr. Marwa and his group, and they also shown that peak BMD is achieved at the spine, hip, and radius is 30 to 35 years. Makkad and their group documented what we have observed, 31 to 40 years. And Patni et al. From the Jaipur also, they observed the peak BMD is achieved between 30 to 39 years. So the classical teaching, the peak BMD is achieved between 20 to 25 years, may not be correct in the Indian setting, and that is an important while diagnosing as well as managing a patient with the young osteoporosis. Now, looking at the etiology of osteoporosis in the young, so the primary causes, the most common in primary causes is the osteogenesis imperfecta, maybe followed by hypophosphatasia and then idiopathic. A word I want to say over here is hypophosphatasia. Though it has been said that it is very uncommon, does not exist in India, but in our setting now, we have the facility to do the ALPL gene mutation in our laboratory, and we are finding almost every month one patient of hypophosphatasia presenting with some fracture or some features to osteomalacia. So that is an important cause of young osteoporosis. Among the secondary causes, any chronic disease can present with the osteoporosis, and maybe the endocrine disorders in the top of the list, that is Cushing syndrome, of course the primary hyperparathyroidism, type 1 diabetes, thyrotoxicosis, hypogonadism, and maybe the most common cause of secondary osteoporosis in young population is steroid intake for some or other reason. And unfortunately, steroid is available in the OTC. That may be another reason for the uh, frequently coming across the patient of the young patient with the osteoporosis. So as compared to the classical postmenopausal osteoporosis, where the primary cause is more common, here in the young osteoporosis, the secondary cause is the more common cause of the osteoporosis in the young. So the another epidemiological study published by Dr. Sandeep Khosla and his group, and they found that idiopathic cause of osteoporosis in young was very, very less, just zero point 0.4 per 100. On the contrary, they found the steroid induced is more common. So we can say that 90% of cases in the young is the some cause is found, and that is that's why the secondary osteoporosis is much more common in the younger people. Another few epidemiological study, one is published by Dr. Biljikian and his group, and where they studied around 100 pre or perimenopausal women below 50 years of age, and they found that secondary causes identified in approximately 50% of premenopausal women, and GIO they found the most common cause of the secondary osteoporosis. Another study by the Spanish group, and they found that the small in number 52 premenopausal women were studied, and they found the secondary osteoporosis found in 40%, and the idiopathic osteoporosis found in approximately 55%. So meaning by that, these epidemiological study says that there is some referral bias is there. Like in previous study by Sandeep Costa, the secondary osteoporosis was found in 90%. While these two subsequent studies, they found the 50% is the cause for the secondary cause of osteoporosis is there. So probably we have to look into our Indian data that what are the common causes and how frequent is the secondary cause of osteoporosis, or the peak bone mineral density not achieved the cause for the diagnosing the osteoporosis in our population. Now coming to the diagnosis of osteoporosis in young. So osteoporosis in young, again, you can divide in two groups. One is children and adolescent, another is young adults. So in children and adolescents, the peak bone mass is not achieved. So obviously you cannot use T-score or the G-score. So we have to rely on the T-score cannot be used. We have to rely on the BMD only. Or BMD sometimes is not very reliable. That's why the different criteria is there. I'll talk to you in the next slide that how to diagnose osteoporosis in the children and adolescents. While in case of young adults or the premenopausal females, the peak bone mass is achieved. So you can use BMD as a reliable criteria to diagnose osteoporosis, or T-score may be used, or below 40 years, G-score is already, Madam Shriram is also discussed in this talk about that. I'll spend a few seconds in this slide. That is an interesting slide. You can see here that first graph in this slide, the first bar is for the female and the second bar is for the male or the boys, girls versus boys. So in the girls, the peak height velocity achieved at the age of 11 and a half years, and by 12 and a half years, the peak bone mineral density is achieved. So there is a gap of approximately 1 year between achieving the peak height velocity and achieving the peak bone mineral density. So during this period, if we study, the BMD will be less only. And that's why there is more chances of fracture, though height is gained, but the BMD is not achieved during this period. Similar in the second bar, that is for the boys. So they are achieving their peak height at the age of 12 and a half years and say 13 and a half years, and they are completing by 14 years or so. So during this period of 6 months to 8 months, there is a peak height is achieved, but the BMD is not, BMD achieved is at the age of the 14 years. So this gap of approximately 6 to 8 months is there. If we study during this period, there may be different result as compared to the study after the 13 and a half years in the females and 14 and a half years in the males. So now coming to the diagnosis of osteoporosis in children and adolescents. So diagnosis should not be made on the basis of the densitometric criteria alone, as I mentioned previously, and they requires presence of clinically significant fractures. They requires clinically significant fractures, and they should be excluded major trauma or road traffic accident, and the fall should be about 3 meters or about 10 feet. Should be the classical fragility fracture we define is that the person's height, but here this is different. And the presence of one vertebral compression fracture, or meaning by that loss of height more than 20% of that vertebra is required to diagnose the osteoporosis in the children. And the second possibility, if we use the G-score as a BMD G-score for the diagnosing osteoporosis, then it should be less than -2. But in addition to that, they should also have the clinically significant fracture history. So more than 2 long bone fractures by the age of 10 years, or more than 3 long bone fractures at any age up to 19 years, then only you can make the diagnosis of osteoporosis. So meaning by that, for the children and adolescent, we have to have the fracture, whether it is a vertebral compression fracture or we have the long bone fracture in addition to BMD. So that is the criteria to diagnose the osteoporosis in the children and adolescents. And this BMD assessment recommended at spine and total body, not at the femur neck. So, or we can say headless BMD is considered for diagnosing the osteoporosis. Now coming to diagnosis osteoporosis in young adults. So there is a different criteria used by the ISCD and IOF. ISCD says that G scores for defining low bone mass, they use G scores, and the WHO T score may be used in perimenopausal women according to the ISCD. While the IOF says that T score less than or equal to minus 2.5 at hip, spine, and or vertebral fracture or multiple fragility fractures are required to diagnose the osteoporosis according to IOF criteria. So there is some divide between the ISCD and IOF, and they use different G score and the T score respectively. And this is important for us also because our peak bone mineral density is achieved little late as compared to the Western database. So that's why that is an important question to answer, that we should use IOF criteria or we should use the ISCD criteria. Though in our department, we do use the T score for that purpose. Now, identification of the underlying cause of osteoporosis in young is of very, very important because if you find the cause of osteoporosis in young, it is very gratifying and the results are very good. So to find the treatment, for treatment of underlying cause often leads to marked improvement in the bone health if you have the clear-cut cause for the osteoporosis. Now question comes how to identify the etiology of young osteoporosis. So first and most important, like any other medical condition, you have to take detailed medical history, clinical examination, investigations, and radiology also plays an important role. And sometimes you may require histomorphometry for especially for the to decide the treatment. Either you want to treat with the anti-resorptive or you want to treat with the anabolic agents and genetic analysis. So detailed medical history that includes age when the first fracture had occurred, renal stone disease, because all these history will indicate for the some secondary cause of osteoporosis. Then clinical examination, height measurement and BMI is important. And the common causes of young osteoporosis is osteogenesis imperfecta. So that's why you look carefully for the blue sclera and poor dentition, that will give some idea. Then facies are very important because that will give idea about the Cushing's disease or hypercortisolism and thalassemia. Joint hyperextensibility or joint inflammation. Deformities help you to exclude the osteomalacia, and signs of Cushing syndrome or thyrotoxicosis, signs of hypogonadism, as well as the proximal myopathy is very, very important to differentiate osteoporosis from the osteomalacia. So here is the patient. Actually, he was having the bilateral femur neck fracture and presented to us, and he was walking with the help of walker and he was subjected for bilateral hip replacement in some hospital outside. Indeed, this patient had a tumor-induced osteomalacia, but this was treated as a young osteoporosis. And once the TI was, say, lesion was removed, the patient was improved significantly without any treatment except the successful surgery of the removal of that lesion. So investigations, we already discussed mineral related to mineral metabolism or for any chronic disease, that is important. And now gradually diabetes mellitus also gaining ground, and especially type 1 diabetes is very, very important, though we don't discuss much about that. So you have to, and the malabsorption may not be very common in the western part of the country or the southern part of the country, but in northern part of country, the malabsorption disorder, especially the celiac disease and lactose intolerance are two important conditions can cause young osteoporosis because of not achieving either peak bone mass or causing the loss of the bone mineral density. Now coming to the how to use the biochemistry, and especially alkaline phosphatase is probably very important to look for the diagnose the patient of young osteoporosis. So I try to make this simple algorithm looking at the alkaline phosphatase. So if the alkaline phosphatase is low, the two possibilities are common. One is hypophosphatasia and second is osteogenesis imperfecta type 2. If the alkaline phosphatase is normal, then possibility is osteoporosis without fracture. And if the alkaline phosphatase is high, then the possibility is osteoporosis with fracture and osteomalacia. So alkaline phosphatase give us a reasonable idea that what we are dealing with, that either patient is having hypophosphatasia cause of osteoporosis, or patient is having osteoporosis, or patient is having the osteomalacia. Uh, well, role of bone turnover markers is not very clear. Bone turnover markers can be used for two things. One is it is if bone turnover markers are elevated, then we have to find out the cause of elevated bone turnover marker. That will help to manage the patient. And bone turnover markers helpful in the therapeutic monitoring of these patients, that if you are treating these patients with anti-osteoporotic medication, what will be the response. Now coming to the radiology, lateral X-ray spine is very important, and the 8 places the BMD also has that facility to the lateral DEXA that will help to assess the morphometric vertebral fractures. And X-ray lateral spine also help to differentiate, or X-ray pelvis to differentiate between osteoporosis and the osteomalacia. May help in identifying the secondary causes of osteoporosis by the radiology. Bone histomorphometry and genetic analysis are important, but I am not going into detail of these three things. So in patients of idiopathic osteoporosis, if you find the cause of the secondary osteoporosis, you treat accordingly that. If you are not finding the cause for the secondary osteoporosis in young patients, in that case you have to do the family screening for BMD and an history of multiple fractures. If there is a possibility or there is a history of Mendelian inheritance, then there is three important causes are there. One is OI, and other is you will look for some genetic mutations. If there is no Mendelian cause is there, then true idiopathic osteoporosis is there, and we may have to do some sequencing to find out any novel mutation. So is one study published recently in the JVMR, and they looked for the primary osteoporosis in young adults. And what they found is that in 50% of patients, they could not find any cause. And another 45 to 50%, LRP5 is the most common cause of abnormality of this low BMD in the young patients. And the remaining is contributed by the osteogenesis imperfecta, WNT1 and DKK1. So treatment is very straightforward. If we have the secondary cause, we have to treat that. If it is a primary cause, you have to supplement calcium, vitamin D, and that is often depends on the patient, doctor's judgment that how to treat that. So on this, I'll take you another interesting case we have seen, and we have a follow-up of almost 10 years. So this 27-year female presented to us in 2010 for her backache during her pregnancy, and that pain persisted even after delivery. There was no history of trauma. Radiology shows the collapse of D12 vertebra, and MRI span showed the reduction in the height of the few vertebrae, and the G score was -4 at the spine. As usual, she was investigated with a detailed biochemical profile. We found the alkaline phosphatase was elevated and vitamin D was low, so she was treated with the vitamin D, and she showed improvement with the vitamin D. So here is the timeline of events over the 10 years of follow-up. So in April 2011, she was started with OCs and calcium and vitamin D. She showed a good improvement in the bone mineral density of 25%, and so OCs was stopped. In 2013 to 14, she was doing fine, and PTH, vitamin D, and alkaline phosphatase is normal, and she was receiving calcium and vitamin D. But again in 2015, after 4 years of the initial event, she started complaining of bone pains and backache. So in 2015, evaluated after 6 months of the symptoms. So BMD was decreased by 5.3% at the spine, and the G score was -3.1. And as usual, we investigated for the lactose intolerance and the celiac disease, that was negative. So bone biopsy was performed, indeed with the bone histomorphometry also, that shows trabecular thinning. And in September 2017, we found that his P1NP and CTX was low. So this is basically that patient has a low bone turnover state, and that was cause for the osteoporosis. So we thought we should treat with the teriparatide in view of the low bone mineral density, low bone turnover state. And for that, she received the treatment for almost 1 year. But there was no symptomatic improvement. So she said, I'm not willing to continue with the teriparatide for 1 more year because there is no improvement. So she was, though there is this G score was improved from the minus 3.1 to 2.7, and but slight improvement in BMD that was not reached to statistical significance or not cross the LSE, you can say. So now we put her on the denosumab, and she received 4 injections of the denosumab, and she is BMD was increased by 4.8% at the spine, but she is still symptomatic. Not our symptoms are improved completely. So this case of the 10 years follow-up, teaching lot of things, that one is pregnancy can cause the osteomalacia kind of picture. We might be confusing with the osteoporosis, and the successful treatment with calcium and vitamin D and normalizing vitamin D can lead to significant rise in bone mineral density. And if the low bone turnover state, maybe choice of treatment will be teriparatide, and after that you can shift to the anti-resorptive therapy after the teriparatide therapy. So in conclusion, I would say that osteoporosis in young is less common, but we come across patients nowadays not that uncommon, and the diagnostic criteria in children, adolescents, and young osteoporosis is different as compared to the classical postmenopausal osteoporosis. Treatment can be very simple or can be difficult. If the secondary cause is found, which is common one, then it is easy to treat. But if they don't have does not have the cause or idiopathic cause of young osteoporosis there, it is difficult to treat. Thank you very much for your patience listening, and I am happy to answer any question and comments. Thank you.
Thank you. Thank you